I would like to start my presentation about three-dimensional preoperative planning of curved periacetabular osteotomy using finite element analysis. I have no COI. Developmental dysplasia of the hip (DDH) is disease with insufficient acetabular formation and shallow coverage, especially common in Japanese. In DDH patients, stress concentrates on the hip joint during weight bearing and develops cartilage degenerations and disappearance. Finally, DDH leads to osteoarthritis of the hip. Curved periacetabular osteotomy (CPO) is a surgery to increase the bony coverage and reduce the mechanical stress by osteotomy of the acetabulum for DDH. In CPO, depending on the direction and the rotation degree of the osteotomized bone, the bony coverage on contralateral side decreases. Excessive rotation of the osteotomized bone causes impingement of the acetabulum and femur during flexion. Three-dimensional preoperative planning is necessary. We need to determine how much to rotate and in which direction. The purposes of this study are to perform the surgical simulation of CPO and to compare the contact pressure according to the rotation angle using finite element analysis. The patients, 23 cases, 24 hips with DDH who underwent CPO in our institution were classified for types using the radar chart. One typical case was selected in each type and included. CD data was analyzed using the finite element analysis software Mechanical Finder version 12. Pre-CPO lateral 10 degree to 40 degrees rotation CPO models and each model with 10 degree anterior rotation models or 10 degrees external rotation models were generated. The mean contact pressure and the contact area on each model were evaluated. I would like to explain the radar chart method. We define the axis parallel and perpendicular to the anterior pelvic plane (APP) and passing through the center of the femoral head. Multiple radial planes were created along this axis, and acetabular coverage angles were measured in each plane. We described these angles using radar charts. This method could visualize the acetabular location and the acetabular coverage on site. DDH type classification according to radar charts were shown in this slide. The radar chart of preoperative and normal groups can show the type of DDH: mild, anterior, posterior, global type. Model generation. STL models of acetabulum, osteotomized bone, cartilage, and femur were created. Mesh generation was performed with a standard size of 4 mm. The loading conditions were 500 Newton for distal femur and 1000 Newton for gluteus medius. Elastic modules were set as follows. Contact element was set between the cartilage of acetabulum and that of femoral head. Lateral 0 degrees to 40 degrees rotation models and with anterior 10 degrees rotation or external 10 degrees rotation. 15 models each type and total 60 models were created. Evaluation. We evaluated the contact diagram of contact pressure, the mean contact pressure and the contact area on the acetabular cartilage in each model. Results. This is a contact diagrams of mild deficiency. Contact pressure of lateral 20 degrees, anterior 10 degrees rotation models was most distributed. This is the mean contact pressure of mild deficiency. Mean contact pressure of lateral 20 degrees rotation model decreased the most. This is the contact area of mild deficiency. Contact area of lateral 20 degrees, anterior 10 degrees rotation model increased the most. Optimal rotation angle of mild deficiency based on mean contact pressure was lateral 20 degrees rotation. This is the contact diagrams of anterior deficiency. Contact pressure of lateral 20 degrees anterior 10 degree rotation models was most distributed. This is the mean contact pressure of anterior deficiency. Mean contact pressure of lateral 30 degrees rotation model decreased the most. This is the contact area of anterior deficiency. Contact area of lateral 30 degrees rotation model increased the most. Optimal rotation angle of anterior deficiency based on mean contact pressure was lateral 30 degrees rotation. This is the contact diagrams of posterior deficiency. Contact pressure of lateral 30 degrees anterior 10 degrees rotation models was most distributed. This is the mean contact pressure of posterior deficiency. Mean contact pressure of lateral 30 degrees anterior 10 degrees rotation model decreases the most. This is the contact area of posterior deficiency. Contact area of lateral 30 degrees anterior 10 degrees rotation model increases the most. Optimal rotation angle of posterior deficiency based on mean contact pressure was lateral 30 degrees anterior 10 degrees rotation. This is the contact diagrams of global deficiency. Contact pressure of lateral 10 degrees anterior 10 degrees rotation models was the most distributed. This is the mean contact pressure of global deficiency. Mean contact pressure of lateral 30 degrees anterior 10 degrees rotation model decreased the most. This is the contact area of global deficiency. Contact area of lateral 20 degrees anterior 10 degrees rotation model increased the most. Optimal rotation angle of global deficiency based on mean contact pressure was lateral 30 degrees anterior 10 degrees rotation. Discussion. Regarding of the direction of the osteotomized bone in CPO, Naito et al. Reported that the osteotomized bone should cover the femoral head with the acetabulum and the osteotomized bone should be horizontal at the loading area. Evaluation and planning based on simple X-ray images is popular still now. There were few reports in three-dimensional and finite element analysis. This study performed three-dimensional simulation. Finite element analysis was used to analyze the contact pressure. There were no reports of preoperative planning for CPO in each DDH type. Our study showed the optimal rotation angle of osteotomized bone in each DDH type based on mean contact pressure. The optimal angle of mild type was lateral 20 degrees. Anterior type was lateral 30 degrees. Posterior type was lateral 30 degrees, anterior 10 degrees, and the global type was lateral 30 degrees and anterior 10 degrees rotation. Preoperative planning for each patient is necessary because each DDH type is different. In our results, contact pressure and area of lateral 40 degrees did not improve as well as lateral 30 degrees. So lateral 40 degrees rotation might be excessive rotation. Excessive rotation decreases the bony coverage of contralateral side and leads to the femoral osteobular impingement. So we should evaluate excessive rotation in CPO. In the future, we will evaluate the optimal rotation angle for each DDH type in more cases for CPO and perform the surgery as planned using intraoperative navigation. We will evaluate the contact pressure after CPO using finite element analysis. In conclusion, three-dimensional preoperative simulation of CPO using finite element analysis was conducted. CPO was a surgery to distribute the contact pressure of the osteobular cartilage. Not only lateral rotation, but also anterior rotation was useful in distributing the contact pressure on the osteobular cartilage. Three-dimensional preoperative planning is necessary for each DDH type. Thank you for your kind attention.